Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to talk about why using standardized, or say maybe a few reasons why using standardized anatomical resources in order to guide your treatment may not be as ideal as you would want. All right, so I'm going to try to throw a couple examples out there to to attempt to increase confidence in the case that simply using standardized anatomical teaching and standardized anatomical resources to guide treatment may not be the most ideal. So the thing that is spoken about probably less than it used to be, in my experience, would be something along the lines of vertebral column segmentation with respect to nerve passage or neural passage. So you talk about the sciatic nerve, you talk about the levels at which the sciatic nerve exits. If I'm not going crazy, L3, oh, no, I'm screwing something up there. Like L5 to S2, something like that. There's different segmentations depending on the particular resource that you utilize. So number one, if you look at a bunch of different anatomical resources and they note different segment levels, vertebral column segment levels for a given nerve, then you immediately on its face know that there is variance. So if you know that there is variance, you can't assume the levels of any given nerve, at least the levels of exit. Okay, so we've got the vertebral column segmentation, the fact that different resources will note different levels for the same named nerve. Then we have vertebral column segmentation versus spinal cord segmentation. So the conus medullaris, or the bottom of the spinal cord in an adult, or we'll use the term adult, but maybe we should say fully grown person. The term fully grown meaning that they're not growing any more past that point in their life, and some people hit that earlier and some people hit that later. So I think physically mature is a more meaningful term. The spinal cord's end is generally L1 to L2 depending on the person. So vertebral column level L1 or L2 or somewhere in between is the normal, common end of the spinal cord. That means that the coccygeal nerve segments and the sacral nerve segments are at approximately the level of L1, L2, T12, right? The lumbar segments of the spinal cord are held in the very low thoracic region. What you have subsequent to the conus medullaris, or the end of the spinal cord, is the cauda equina. So the horse's tail, so Latin for horse's tail, which is essentially a description, an observed description of how the nerves, when the vertebral column is pulled off of the spinal cord, how the nerves descend in an organized fashion, looking like strands or looking like a horse's tail. So at the conus medullaris, all you have is a bunch of strings or ropes or cords going downwards or in an orderly way. So let's just say we're going to talk about L1. The L1 segment of the spinal cord is going to, again, be low thoracic region, and it's going to come off slightly laterally and inferior and course downwards until it exits at the foramina between L1 and L2. I believe that's the proper foramina. Maybe I'm nuts. No, that should be the proper foramina, the proper intervertebral foramina. It may be higher, I may be misnaming it, so please excuse me if I am. But it'll go, sort of lateral and inferior and then exit. And then the same thing, so the L2 segment will be just below that on the spinal cord, which is going to be low thoracic region, and it'll course downwards and then lateral and go out at the appropriate level. The past L1, L2, so the nerves, the spinal nerves as they come off of the cord will again be higher than the L1, L2 level-ish, and then they'll course downwards and lateral at the appropriate level. That's the cauda equina. So cauda equina syndrome is where essentially the entirety of those nerves have some form of paresthesia. So the primarily we're talking about low lumbar exit, right, or mid to low lumbar exit nerves, and then sacral nerves, or nerves that would be noted at sacral segments on the cord, and exiting that way through the vertebral column, or the bony framework. So you've got some paresthesia, so you've got sciatica type symptoms. You also will have often issues with control of excretory function, right? Because of the location of the conus medullaris and the travel of the cauda equina, the physical mechanical issue can be almost anywhere from T12 all the way down to the sacrum. So we've got a variance due to the conus medullaris and the cauda equina between vertebral segmentation and cord segmentation, right? So the cord is shorter than the vertebral column. And then you have this mechanical traverse of nerves through the lumbar column and then exiting at appropriate levels. So anywhere essentially in the lumbar column and probably T12-ish, the low thoracic region, you can harm the sciatic nerve mechanically speaking. It's not always going to be the case, or you could have a problem, say a mechanical problem, somewhere in the lumbar column that the sciatic nerve from the cauda equina is going, or the roots from the cauda equina are traversing, and you may have no problem with the actual nerve, or you can have a very tiny issue somewhere in that lumbar column that could then centrally impact the sciatic nerve as the roots traverse through the cauda equina to become the sciatic nerve. Because of this variance, counting vertebral segments as a guide to where the problem, the mechanical problem, if it does exist, that is generating the issue for the sciatic nerve, is sort of moot on its face. Because you can't trust that everybody's conus medullaris is in the same spot, that every sciatic nerve is built the exact same way, that every mechanical problem you find in the lumbar of the low thoracic region is going to do this or that to anything. The simple assumption is that when you get down closer to the bottom of the lumbar column and you get into especially L5S1, that's where you're going to have problems with the sciatic nerve. No, you could have problems with the sciatic nerve and its roots as high as T11, T12. So the counting and the location of the vertebrae carries a lot of assumptions that often doesn't appropriately consider the difference between vertebral column and spinal cord segmentation, right? So again, just keep in mind, cord is shorter than column. Neural structure is shorter than bony structure. So we've got that to consider. We've got to acknowledge the variance in nerve setup for different people, the difference in mechanical impact on nerves for different people. We have to consider things like vascular supply of nerves. It's poorly described in anatomical resources because it's so highly variable. Some people have nerves with better blood supply than others. So the vasonervorum is the proper term. So the vasonervorum is varied between people. Some people have better blood supply for nerves, which will predict better peripheral nerve healing from injury to peripheral nerve if you have better vascular flow. Whereas if you have poor vascular flow, if you have an injury to a nerve in an area that happens to be poorly supplied in you, which we don't know because it's so variable, then your nerve is less likely to heal. Whereas if blood perfusion in that particular region or generally to your nerve is good, then you're more likely to heal from whatever mechanical insult has happened to that nerve. So we've got variance in nerve structure, we've got variance in cord length versus vertebral column length. We have normal variance in blood flow to nerves. We have normal anatomical variance in different people, right? So if you look at, or even within a given person, if you look at the concept of symmetry within a given body, asymmetry in bony structure is identifiable and common. Larger variances in bony symmetry bilaterally are going to likely indicate variance in use pattern, one side to the other. Not always. Something along these lines can be classically viewed through the skeletons of people with particular professions. So I think it is reasonable, if memory serves me properly, to suggest that archers, especially archers in the past who use heavier bows, so something like an English longbow, would have greater development on one side of the body just because of how they had to operate that bow, operate that weapon. You can see these things in bony structure. So bony asymmetry is normal. Larger variance in bony symmetry is probably due to use patterns. But bony asymmetry doesn't necessarily indicate dysfunction, and it doesn't necessarily indicate sensory state or state of internal sensation. It'll often relate to it, but it doesn't necessarily indicate it. Just because there's more variance in symmetry of bone one side to the other doesn't immediately suggest that you can predict where the person is going to feel a given sensation. It will often relate with respect to the relationship between things, where something is a different shape and then you feel something. Sometimes it's just because it's in the same person at the same time, and other times it's causal, right? So that's tough to pick apart. There are normal variances in organ size, organ shape, organ position. Organs move themselves around. Well, they don't move themselves around so much. They tend to have movement in relation to themselves within the container that they sit in, within the abdomen primarily, and within the thorax to a lesser degree. There's lesser organs, but they are highly mobile. So the heart and lungs are highly mobile, where the abdominal contents don't move as much with relation to each other, but they do move a decent amount in relation to how a person moves. So when a person walks, when a person runs, there's going to be normal movement of the cavity. There's going to be impact, so there's going to be an up and down movement. Respiration is going to create an up and down movement. So these are very, very normal things. And the organs tend to, in the abdomen specifically, organize themselves through normal movement. So an example of this is post-abdominal surgery or open abdominal wall surgery, where organs are moved out of current place. When they put them back in, they don't try to organize them. They sew the person back up, and they generally suggest walking as much as you can. And the organs tend to find their own way home, their own place back to how they relate to one another. So keeping in mind that the organs do move a decent amount in relation to other normal movements, primarily respiration, as well as locomotion or movement, that the organs are different shapes, they're in slightly different positions. Sometimes they are reversed in their orientation, say with respect to situs inversus, specifically within, I think situs inversus is included to some degree in the thoracic organs as well, so heart and lungs, but definitely with the abdominal organs. There is somebody that I have had the chance to speak to who has a history of doing a decent amount of heart ultrasounds, and they note that through experience, you start at the angle of Louis, so you start in and around the sternum, and then you start to move off of that to the place where you think the heart will be, and often enough, the heart is not in the location that one would think it would be while operating that ultrasound, so the diagnostic ultrasound. So the heart is commonly in a different position than would be expected, and this is reported through people who do thoracic ultrasounds looking for the heart. So the heart can be different sizes, different shapes, different angles, different positions, and that's not weird, right? So to just go to the sternum or go to the left of the sternum and say that, you've done something to the heart by moving superficial tissue, it just suggests that you don't actually understand living anatomy of humans. If you understand the living anatomy of humans, you will know that it is unreasonable with high confidence to claim that an organ is in a place that you think it is and doing the thing that you think it is. It is more reasonable to say, hey, I'm in the general region of this thing. Maybe the fact that this superficial structure or this superficially observable motion restriction is present, that it may be doing something mechanical to this other structure because it's likely in the same area, but I don't know. That is more reasonable with respect to having an externally observable, reasonable understanding of living anatomy. So, to say flip back to the conus medullaris, if you look commonly at image reports of the vertebral column and the spinal cord, you will note that there is often the inclusion of the level of the conus medullaris. I have seen conus medullaris reported at T12, and I have definitely seen it reported at L2. So just to show the difference in what I've seen, and I haven't seen a ton of image reports, I've seen a good amount, but I haven't seen droves and droves of them. But in the smaller amount compared to, say, a radiologist, I've seen variance from T12 to L2. So knowing that is a thing that exists, that variance between the level of the conus medullaris, I cannot then overlay a mechanical dysfunction to an explanation of why somebody is feeling what they're feeling or why somebody is moving the way they're moving, because there is variance that I'm aware of, and I know I can't tell where it is from the external environment of observation. All of this then can be wrapped up in a term from a paper that I've spoken about. And I think it was about a year ago that this paper ended up in the Journal of Osteopathic Medicine. And the term is anatomical possibilism. So osteopathy traditionally, or maybe not traditionally, historically, has attempted to explain everything it finds by tracing anatomy in relation to located dysfunction. If you consider that there is very normal variance, say with the vertebral column, right? So you look at the vertebral column and you look at the ability to identify specific landmarks and generally spinous processes. You're never going to find transverse processes with any form of reliability. It's not happening. They're not exposed enough. They're deep to too much muscular tissue and adipose tissue to be reliably identified upon palpation. But spinous processes are midline and tend to be covered by far less adipose tissue. Generally, they're not going to be obscured by muscular tissue, but they are going to be obscured to some degree by adipose tissue, especially as you get to the lower portion of the vertebral column. If you look at the accuracy of identifying spinous processes, which are pretty big and pretty much in the middle, and saying this is definitely L4, this is definitely L3, there is, but I think the top accuracy I've ever seen is about 80% with accurately identifying, I think it was L3. And that depended on, to some degree, the experience of the practitioner, as well as the BMI of the patient. So BMI can be a contentious topic. BMI as an indicator of very rough things is helpful. It doesn't mean it's absolutely predictive of specific things, but it does mean that it is a nice rough predictor of some things. So a higher BMI is generally associated with higher levels of adipose tissue in a given human in varying distributions. But again, it doesn't necessarily indicate other things. So I know that it's a contentious term, but in the research that I'm referring to, BMI was used as a very rough proxy for higher levels of adipose tissue, right? So the higher the BMI, the more likely somebody has more adipose tissue, which would, especially with respect to spinous processes, be more likely to obscure lower lumbar spinous processes. Doesn't mean it absolutely does, because there's variance here, but again, just so that I can attempt to be fair and clear. So I'm reporting on what the research used as measurement and why they used it and what it was suggesting, but also noting that the term is contentious, or the concept is contentious. So with varying amounts of subcutaneous fat or adipose tissue, some reasonably large structures in spinous processes can be obscure enough that it is actually hard to count to L3. So the other thing with, say, identifying appropriate lumbar levels is you do not know without an image if somebody has 4 lumbar vertebrae, 5, or 6 lumbar vertebrae. In all likelihood, they have 5. But they could have 4, so they could have a lumbarization. They could have a sacralization of L5. That's the one. Or they could have a lumbarization of S1. So they have a lumbarization of S1, they have 6 patent lumbar vertebrae. If they have a sacralization of L5, they would have 4 patent or movable lumbar vertebrae. You do not know this unless you have an image. So if you don't know how many lumbar vertebrae they have, and you know that it's not abnormal for people to have a lumbarization or a sacralization, then your likelihood of finding something that should ideally be relatively identifiable in L3, because you can sort of triangulate between the bottom of the lumbar column and the top of, or sorry, the bottom of the lumbar column and the bottom of the thoracic column. So if you could find rib 12 and you follow it in, you should be at T12. However, people can have 13 ribs, so they can have supernumerary ribs on L1. They would not likely be large, but they could obscure your palpation. So very normally, or not very normally, it is not uncommon to have variations in the amount of ribs that somebody has, as well as the amount of patent lumbar bones they have. So I have in my past had a patient who had supernumerary ribs, so they had L1 ribs, and they also had 6 lumbar vertebrae. So they had a lumbarization of S1. I had no idea until I was told because of imaging. And they did not show any truly abnormal movement patterns that would have been clearly indicative of those variations. It was normal to them, and that's all there was to that. So I have personally experienced abnormal may not be the appropriate term, varied anatomy that I did not know existed, but was told later through imaging that it existed. I didn't necessarily identify something clearly different. I just noticed where it wasn't moving. I worked on that, and the person had positive results. So all of these concepts, all of these things to say that it is easy to know that anatomy is normally varied from standard anatomical resources. You are experiencing it if you're a hands-on practitioner, and you probably don't know unless an image is present. Therefore, with all of this normal variance, the specific ones I've talked about and others, it is unreasonable to make mechanical explanations with respect to what somebody is feeling based on a standard anatomical text. It is not a horrible place to start, but it is not properly explanatory in a lot of cases by way of using that standard anatomical resource or that standard anatomical knowledge to predict why somebody is feeling what they're feeling or moving the way they're moving, because you have to make too many assumptions. You have to assume that the text properly represents the person you're working on. And it often does, but it also doesn't, right? So you want to be aware of that. This is a case I've made before, just chose to make it again because I had a conversation with somebody where they had brought up the term anatomical possibilism because I was speaking to them about teaching osteopathy and some of the challenges with building educational frameworks and curriculum. And we were speaking about how you could pull in best practices from health science education or health professions education and meld that with teaching a primarily hands-on profession that works in the external environment of observation. So I was motivated by that. Thank you for listening this far. Hopefully you learned something, and we'll talk again soon.